Welcome to the deep dive. We're here to, cut through the noise and get right to the core insights. Today, we're diving into a really fascinating case report. It's particularly relevant for us as specialists in anesthesia. This case highlights some pretty unique challenges when providing anesthesia for, well, urgent airway procedures in our tiniest patients.
Indeed, yeah. This deep dive, we're going to explore a case involving rigid bronchoscopy in an extremely premature baby, an unintubated micropremie. Our mission really is to unpack the anesthetic challenges they faced, the critical decisions, and, what vital lessons we can take away from managing similar high-stakes scenarios.
Okay, let's unpack this. It sounds extraordinary. We're talking about a baby just 1 day old, 560 grams,
Tiny.
born super early, 23 weeks and 6 days gestation, presenting with labored breathing. What's really striking, I think, is that despite multiple intubation attempts
Right.
by the NICU team, including one with video laryngoscopy where they saw the ETT pass the vocal cords.
Visual confirmation.
Exactly. But still, no detectable end-tidal CO2. At-seat CO2 just wasn't there.
Zero. Nothing on the captograph.
So eventually, she was extubated, placed on nasal bipay. Pretty standard settings there. PINS 16, PEEP 6, FiO2 0.4. And then transferred for an urgent rigid bronchoscopy to rule out a TEEF, a tracheoesophageal fistula.
Okay, so this right here raises a big question. When you're faced with that persistent lack of CO2, after what looks like a successful intubation, what's going through your head? What's the differential?
Right. What are you thinking?
Well, the team here, they methodically worked through it. First, rule out equipment issues, right? Always check your gear.
Standard first step.
Then they looked at anatomical causes, like the TEEF they were going for the bronchoscopy to rule out. The bronchoscopy itself was interesting. It showed an edematous epiglottis, a couple of lacerations on the posterior pharyngeal wall, maybe from the intubation attempts,
Possible.
and mild tracheomalacia, but importantly, no TEEF. And they could pass an OG tube, so esophageal atresia was pretty much out too.
Okay, so anatomical obstruction wasn't the primary issue, it seems, given how fragile she was and needing to keep her breathing spontaneously. What was the anesthetic plan for the scope itself? That sounds like a real tightrope walk.
It absolutely is.
Yeah.
They went with TIVA, total intravenous anesthesia, used incremental dexamethasone boluses, adding up to 4 mics per kilo would fee,
Okay.
and the propofol infusion running at 300 mics per kilo per minute.
Right.
But the challenge popped up again when they tried to intubate for the procedure. They placed an uncuffed 2.5 millimeter ETT over a 2 mil telescope.
Standard technique for this.
Exactly. And yet again, no chest rise, no breath sounds bilaterally, and still no at-seat CO2.
Even with high pressures?
Even cranking inspiratory pressures up to 40 centimeters of water, still nothing.
Wow. Okay, this is where it gets really puzzling, like you said. So what did they do? How did they break through that persistent lack of at-seat CO2, and what did that tell them?
Yeah, this is the critical moment, really. After about a minute or so of applying sustained high-peak inspiratory pressure, but with shorter inspiratory times.
Kind of like recruitment maneuvers.
Sort of, yeah, like really trying to pop open those collapsed lung units. They finally saw a subtle increase in chest rise. Just a little bit.
Okay.
And then finally, ETCO2 appeared on the monitor. That maneuver was absolutely key. It strongly suggested the problem wasn't anatomical blockage, but really profound, ineffective ventilation.
Why? What was causing that?
It pointed towards severely reduced lung compliance and marked adhesive atelectasis, just sticky, collapsed alveoli, all in the setting of surfactant deficiency, which, is the hallmark of neonatal respiratory distress syndrome and RDS in these extremely premature babies.
Right, the classic picture for that gestational age.
Exactly. Things like, say, severe bronchospasm or cardiovascular collapse just didn't really fit the clinical picture at that moment.
The report also mentions some pretty scary moments during the scope.
Yeah.
A brief but severe desaturation, SpO2 down to 37%,
Very low.
and bradycardia, heart rate of 20, needing epinephrine.
Yes, significant event. And later on, they did find and address a hemodynamically significant PDA, a patent ductus arteriosus.
Okay, so connecting those dots?
If you put it all together, the fact that she didn't get surfactant before all this seems pretty critical. Surfactant replacement is, well, it's the main treatment for NRDS.
Standard of care.
Right. Giving it up front could have potentially optimized things quite a bit for ventilation.
Yeah.
We can reasonably think that maybe it would have prevented that whole delay in getting at CO2.
By reducing the atelectasis.
Exactly, by mitigating that adhesive atelectasis. And then maybe they wouldn't have needed such dangerously high inspiratory pressures.
Reducing the risk of barotrauma?
Precisely. And there's actually research showing the difference between end-tidal CO2 and arterial CO2 decreases after surfactant is given. So that kind of supports this idea.
So wrapping this up, what's the big takeaway for you, the specialist listening, when faced with these incredibly complex situations? This deep dive really drives home the profound impacts surfactant deficiency can have on managing the airway and breathing in these micropremies. It's a stark reminder, isn't it? We need to adapt our strategies when the standard responses just aren't giving us what we expect.
Absolutely. This case really highlights, first, the need for sharp critical thinking. When you don't see that ETC2 waveform, don't just assume the tube is misplaced if you saw it go in. Second, you need a super high index of suspicion for NRDS in these tiny babies. And third, just how crucial multidisciplinary teamwork is. NICU, anesthesia, surgery, everyone working together. For me, the most impactful lesson is realizing sometimes the issue isn't just getting the tube in, but preparing the lung itself before you even try to ventilate, making it receptive. What about for you? What stands out most from this deep dive?